The subject sits on a table. The involved shoulder is flexed to 90 degrees, the elbow is fully extended, and the forearm is supinated. The examiner places one hand along the volar aspect of the subject's forearm and the other hand on the proximal aspect of the subject's humerus near the area of the bicipital groove. The examiner resists the subject's attempt to actively flex the humerus forward. Tenderness and/or pain in the bicipital groove is a positive finding that may suggest bicipital tendinitis. The subject sits with the involved arm relaxed at the side and the elbow flexed to 90 degrees. The examiner stands on the involved side and with one hand holds the subject's arm just above the elbow crease. The examiner's other hand is placed over the involved acromioclavicular joint. The examiner applies gentle downward pressure on the arm, noting any movement at the AC joint. Pain and/or movement at the scapula inferior to the clavicle is positive, indicating acromioclavicular and/or corticoclavicular ligament sprains.
The subject sits. The examiner stands with one hand on the posterior aspect of the subject's shoulder to stabilize the trunk, and the other hand grasping the subject's elbow on the test arm. With the subject's trunk stabilized, the examiner passively and maximally horizontally adducts the test shoulder. Superior shoulder pain is indicative of acromioclavicular joint pathology. Anterior shoulder pain is indicative of subscapularis, supraspinatus, and/or biceps long head pathology. Posterior shoulder pain is indicative of infraspinatus, teres minor, and/or posterior capsule pathology.
The subject sits with the forearms and hands resting in the lap. The examiner stands with the proximal hand grasping the subject's scapula superiorly, and this is the distal hand grasping the subject's elbow. With the scapula stabilized, the examiner applies an inferior distraction force with the distal hand. Excessive inferior humeral head translation with a visible and/or palpable step-off or sulcus deformity immediately inferior to the acromion is laterally indicative of inferior and/or multi-directional instability. The subject stands with the involved arm abducted to 90 degrees. The elbow is extended and allowed to rest on the examiner's shoulder. The examiner stands to the side of the subject and claps his hands together around the upper and middle thirds of the humerus. The examiner attempts to glide the humerus in an anterior and inferior direction. Excessive gliding of the humerus may be indicative of anterior and/or inferior glenohumeral instability.
O'Brien test. The subject sits or stands with the test shoulder at 90 degrees of forward flexion, 30 to 45 degrees of horizontal adduction, and maximal internal rotation. The examiner stands with one hand grasping the subject's test wrist. The subject horizontally adducts and flexes the test shoulder against the examiner's manual resistance. The test is then repeated with the subject's arm in an externally rotated position. Pain and/or popping that is present in the internally rotated position but absent in the externally rotated position is indicative of a SLAP lesion. Pectoralis major contractor test. The subject lies supine with both hands clasped together behind the head. The examiner stands directly behind the subject. The examiner passively moves the subject's elbows towards the table. The subject is asked to relax the upper extremity musculature during this movement. A pectoralis major muscle contractor is suspected if the subject is unable to passively have his elbows reach the table.